Hi, my name is Mo Pindari. I'm an orthopedic surgeon and academic at McMaster University, and I have the pleasure today of chatting about fracture care, COVID, as well as a number of non-operative treatments that have become more important now than ever. Let me introduce Dr. Michael McKee. He is a professor and chair in the Department of Orthopedic Surgery at the University of Arizona, the College of Medicine in Phoenix. Hi, Dr. McKee. How you doing?
Hi, Mo. I'm very good. Thank you very much.
So, bone stimulation is broadly, sort of a minimally, if not non-invasive approach to managing a host of issues, fractures being one of them. How do you decide? So, for example, in this particular case, someone subs to you a bone stimulator under the umbrella of all of them, and then there's ultrasound types, which is the low intensity pulsed ultrasound. Then there's, electrical stimulation. There's a host of those. What was it about ultrasound? And I'm presuming you're talking about low intensity pulse ultrasound device, but in that particular case, what was it that got you interested in that?
So it's a bit of a long story, but I used low intensity pulsed ultrasound. That's my go-to device. I had some experience with electronic devices back in the day, electromagnetic fields, et cetera. I didn't find them very useful. It's totally anecdotal, but there were some papers out that would suggest they're not all that terribly useful either. Ultrasound or LIPUS for stimulating bone regeneration. So I started using it on some patients back then, and I was amazed really at how much it made a difference. It really did seem to make a difference in those individuals.
And are there specific groups that you say, okay, this group is ideal for this? I think you've talked about sort of the non-union in a patient at risk. I mean, would you characterize it beyond that, or are there, or in what other groups might you consider using a LIPUS device?
So a straight, stable, non-infected long bone, delayed or non-union, that's behind where it should be. That's the idea in a healthy patient or patient whose other things have been corrected. That's the ideal indication for the use of LIPUS in me, in my practice. In some certain patients where you can see that coming, so you fix, again, let's say a grade 2 or grade 3 open tibia fracture in a smoker whose diabetes is marginally controlled, you see that high-risk patient coming. I think there is some indication that prophylactically treating that patient with a LIPUS type device may well be a good idea in that setting.
Like you speak a little bit to that moment where you thought, okay, this is going to be a potential useful adjunctive treatment, for you as you're managing these complex fractures, whether it was limb lengthening or now non-unions, those patients at risk. Do you have like that in your mind, that one patient that you think of, like I really didn't think it was going to have an impact, and that switched me, like that fracture, in my mind would not have healed. I tried it, it did heal. And I guess I go further to say, do you use that example when you're explaining it to patients who for the first time have never heard of it? So they're wondering what this approach is and why not just operate on me, kind of thing.
Yeah, for me, it was a patient in the Lizeroff frame. It was an interesting story. She'd been in a bad car accident. She was about 16 years old and had a head injury that was so severe they said she wouldn't survive. And she had a femur fracture, and it healed about 5 centimeters short. And needless to say, she walked into my office a year after the accident with a terrible limp, a short leg, and perfectly conversational. Not only did she survive, she's probably smarter than I was at that point. So I said to her, we need to lengthen your leg. And this was before we had lengthening over nails. There were no self-lengthening nails. There was no monorail technique. It was just pure Lizeroff. So we put the frame on her femur, lengthened her out, which went well. And when patients are actually being lengthened, it's like an active time for them. They see correction, they see things going better, and they're very happy. But then they just get to where they're supposed to get to, and they just sit and wait, which is the phase where you wait for the regenerate bone to heal. And that can be killer for patients. Just sitting there week after week waiting to get this frame off. And it was taking a long time in her. And we added the ultrasound device in her, and literally within a couple of weeks, things just started sprouting.
So when you then speak to a patient who is, who has, let's say, a non-union, you're considering options, and you're thinking that, a LIPUS device would be a potential alternative for them. What is your basic discussion with the patient in terms of informing them about the reality of their situation?
So if in that category I spoke of, where they're straight, stable, and not infected, and they've got reasonable soft tissue coverage, I tell them this may save you an operation. Sometimes people say, I just want it fixed right away. Like, I'm done with this, I want it redone. And I'll say, okay, well, fine. But if they're reluctant to have another surgery, or circumstances dictate that they shouldn't for whatever reason, then to me, the LIPUS is a potential a salvage technique for them that may well save them an operation. And really, there's very little downside to it. It's not that inconvenient. You put on for 20 minutes a day. There's compliance measuring devices now in the device, which help me to know if patients are actually using it. There's really, as far as I'm aware, no real complications from it, except maybe for cost, and you could argue about that. So really, there's no downside to giving it a shot in that kind of setting, and often you'd be pleasantly surprised.
So then, and maybe my closing statement or my closing question to you on this one is, how do you then talk to colleagues, right? So there's a variety of, surgeons who would say, oh, I'm a full believer. I believe the evidence is strong. I believe it works. I've used it. And then there's a group of people who haven't used it, and quite frankly, may not always be aware of the evidence, or have heard a paper, or have heard someone say something. How do you interact with colleagues around, the use? I'm sure it comes up at rounds, and you're saying, oh, okay, I think this patient needs this, a low intensity pulse ultrasound. In this case, let's say an exogen device. And then you have someone else in the rounds room say, well, I'd never use that. What would be your, I guess, debate or your discussion to help that person understand why you're using it? Or is there such a thing?
If that person said, I've never used that.
Yeah.
And my reply with one of Dr. Schatzker's famous quotes was, I put it to you, sir, that you have never read a book. So by that, I would mean that there is some good evidence out there, and you should read the literature carefully on it. And if you do that, it's not an instant quick fix. And so many people in our society, both doctors and patients are looking for that quinstant, absolutely instantaneous quick fix, like another surgery, let's get it done, which is fine. But if you're not interested in that route, either as a patient or a doctor, and you want to try something that has some pretty good evidence behind it now, then LIPUS would be an option. And my personal experience with that has paralleled the literature, which is that it's bailed us out of some pretty tough situations where 9 out of 10 people in the room would say that's never going to heal, and it actually does heal. And I mean, we've got all case reports and things that we show that would suggest that's clearly the case.
I can't thank you enough for sharing a bit of time talking to us about evidence and your surgical practice, Dr. McKee. Thanks so much.
Thanks very much, Mo. Great to chat, as always.